Hello, my name is Alan Prost, and I'm presenting some work I did on the NeoPuff resuscitator, looking at how it works in the study of ventilator-patient interactions. This is a talk that was prepared for the Canadian Society of Respiratory Therapists for a webinar. First off, it's important for me to disclose that I'm not making any money from this presentation. I have no financial interest in any of the information presented to you today. I'm a SAIT employee, and I did this as part of my work on my spare time in our laboratories. I have no association with Ingmar Medical or Fisher Paykel, the producer of the NeoPuff, or Ingmar Medical, the producer of the ASL5000 Tesla. Because this talk can be used for learning credits for your professional credentials, I am stating my learning objectives, and today it is to describe the methodology and results of simulation testing to measure the capabilities of the NeoPuff resuscitator. The objective of that is to define the advantages and disadvantages of the operational capabilities of the NeoPuff resuscitator in comparison to other respiratory devices. Originally, the purpose of the study that we undertook was from some work that Wald and some others did when they were looking at different devices, and particularly the expiratory resistance of the NeoPuff resuscitator. So they were quantifying and examining the expiratory resistance of the NeoPuff resuscitator and some other ventilators, and that's what got us interested in this work. And our objective in thinking about this was to define the operational parameters, the optimal operational parameters of the NeoPuff resuscitator to use in our neonatal intensive care units and at the delivery rooms. I do have my own personal objectives for this presentation, in that I'm hoping to encourage other respiratory therapists to do some fundamental research within our profession, to look at different devices and study patient ventilator interactions so that we can define what modes and what is the best settings for each individual patient. We should be experts in this area. I'm also an advocate of using things like the ASL5000 or lung simulators in the education of respiratory therapists, so we get a chance to actually play with these ventilators and watch and measure patient ventilator interactions. Unfortunately, that's something that many working respiratory therapists do not get to do because they're actually doing patient care. So I'm not going to go into a lot of details about the methods of study or how the study was done. This is not a review of the methodology here, but just a quick review to show you some of the things that can be measured and how we looked at this. So for the basic study of the NeoPuff, we used the ASL5000 lung simulator, and we use that to simulate a neonatal patient who is both apneic and spontaneously breathing. Also, some of the data was verified by using an external pressure and flow manometer with the NewView pressure manometer recording system manufactured by Michigan Instruments. So if you're not familiar with the ASL5000 Tesla, I can tell you a little bit about that. It's a very precisely computer-driven device that very accurately creates the lung characteristics of both adult and neonatal patients. It uses a electromagnetically controlled cylinder inside to mimic both spontaneously breathing and things like compliance and resistance changes, and you can actually have dynamic compliances, so it's not uniform or a linear relationship. So you can actually create very realistic lung models by using this. And so it comes up and has a deriving a screen where you can set all these elements up, and you can watch the pressure, flow, and volumes delivered to the ASL5000. So it's a really precise tool. And the way I used it was I used it hooked up to the NeoPuff resuscitator, and I was delivering breaths to the ASL5000. And I used this little endotracheal tube here to create a little resistance in the system, and I was mimicking the tracheal conditions of a neonatal patient. I used a 5.0 endotracheal tube because that's approximately the size of a trachea of a neonatal patient. I know that because you can comfortably put about a 3.5 endotracheal tube inside the 5.0 tube, and that's how I came up with using the 5.0 for spontaneous tracheal model that you'll be seeing and I'll be talking about later. So with the ASL5000, you create the conditions for the neonatal patient, and I've got just a little table here that shows some of the basic settings that I use. So you can see I've got my compliance here set at 0.8 mils per centimeter of water pressure. I've got a linear resistance that I had controlled. I set a spontaneous rate, even though you can control that by the amount of pressure or inspiratory effort that's being controlled. So in this particular instance, I've actually got a passive model, so the patient is mimicking being unconscious. So we were just ventilating the neonatal test lung as an unconscious patient with no respiratory efforts. You'll notice that in some of the next models I'll be talking about where we actually changed this, and we did measure very uniformly a patient's spontaneous inspirations and exhalations, and looked at that in comparison to other devices such as the servo-eye ventilator and the CPAP. So once I had the ASL5000 set up, we always calibrated all our NeoPuffs to deliver breaths of about 20 on 6 centimeters of water pressure. And you'll see something that I had to do was alter this PEEP pressures to make sure that they were actually achieved. So I'll be talking about that in the later data. Then we just ventilated the ASL5000 just as a passive lung. So I would just manually control the NeoPuff to deliver a breath of with a peak and pressure of 20 and a PEEP of approximately 6. And I tried to make that as accurate as possible. And then I would capture all the data on the ASL5000. It's got a very precise mechanism for capturing the data and doing its analysis. So all the testing was done, measuring the flow, the pressures, the volumes delivered on the ASL5000, and used a very precise data analysis after the data was captured. So this slide here shows what the data looks like when you capture it. It's combined on here. I've got all the elements of flow and pressure delivery, and you can look at one or multiple breaths on the data screen on the ASL and then capture this, and that's what you'll see captured and redrawn. Well, not redrawn, but displayed in various ways in the data that I'm going to show you about doing this experiment. So one of the first things we looked at was to measure the differences by adjusting the background or the driving flow rate through the NeoPuff ventilator. And so we used flows of 6, 8, 10, 12, and 15 liters per minute. So this is the flow that you have, the continuous flow going through the circuit of the NeoPuff resuscitator. And then we measured very precisely the both the inspiratory pressures, as you see here on the pressure graph, all right, and the flow rates. And what you'll notice is that we also measured the tidal volumes, and here and below is time. So this is a combined scale of both pressures and flow. All right. So what I'm showing here is that you can, I think I can demonstrate that at very low background flow rates, you get a very kind of tapered inspiratory flow like this, and then when you increase the background flow, not surprisingly enough, you get a very sudden increase in inspiratory flow and a slow decline as lung and mouth pressures become closer into equilibrium. There's very subtle differences in tidal volume delivery, but actually the tidal volume delivery was more about the pressure gradient delivered to the test lung, so it's pretty uniform, with variations of usually less than about half a centimeter or half a millimeter of water. But what is surprising was that as you increase the background flow, the pressure manometer on the NeoPuff itself, because of some internal mechanism, becomes inaccurate. At the lower flow rates, the PEEP you set on the NeoPuff is the PEEP that you get. So you can see I've got 6 set here, and I'm getting 6 delivered to the patient. And by studying 5 or 6 different NeoPuffs, and also having the Foothills Hospital do their own verification of this, no matter which NeoPuffs we put on, we saw the same relationship, that as you increase background driving pressure, you had to adjust the PEEP differently. And what it means is that you actually have to set the PEEP much higher on the NeoPuff to get the pressures actually delivered, or the PEEP pressures actually delivered. So as an example, and this is pretty averaged out over 5 or 6 ventilators done repeatedly, at a background flow of 10 liters per minute, there's about 1 centimeter pressure difference between what you observe and what's actually delivered. So if you set 6, you would only get 5. So we increased it to 7 so that we were actually getting a delivered 6 centimeters of PEEP. And 15 liters per minute, you can see I had to increase it by about 1.5 centimeters of water pressure to get the delivered PEEP. And that's an important aspect of using something like the NeoPuff. Another observation you can make from these graphs and this data here is that you can see when you're looking at, when you set the background flow rate to 6 liters per minute, it becomes a limiting factor for the inspiratory flow delivered to the patient. Where when you set the background flow at 15 liters per minute, we're getting peak inspiratory flows of about 12 liters per minute. And what this tells me is that now our driving inspiratory flow to the patient is a result of that pressure gradient and overcoming resistance, and not a limiting factor of the flow being utilized through the circuit of the ventilator. So that might be an important consideration, and that explains why you're seeing this nice, sharp, high peak inspiratory flow. That's probably due to that classic equation of resistance equals change in pressure over flow. So instead of the background flow being a limiting factor, such as at the lower flow rates, when you set these high inspiratory flows, we're probably actually working with the true, overcoming the true resistance, and the flow result is of the pressure gradient. One more significant observation I think you can make from this data is that the TI dynamic in here, the amount of time it takes for equilibrium to be achieved at the lower flow rates, is quite a bit different than at the when you set the background flow rates a little bit higher. You'll notice that the TI dynamic is about anywhere from about 0.4 seconds, and gets down to about 0.3 seconds or so here when you're using the higher background flows in the NeoPuff. Now this can be quite significant, I think, when you're looking at ventilating at higher respiratory rates, such as 50 or 60 breaths per minute, because we want to limit that TI so that we don't have breath stacking. So if the duration or the time it takes to get equilibrium is of concern to you, you might want to choose a little bit higher background flow rates. So this close-up diagram here at 10 liters per minute shows how your TI dynamic can be reduced a little bit by choosing that higher background flow rate. And you can see I've got almost entirely all the flow being delivered, or pressures being delivered, at about 0.3 to about 0.4 seconds using the higher inspiratory flow of about 10 liters per minute. And I think that could be an important consideration when choosing what flow rate to use with the NeoPuff. Now, the original purpose of our study was to look at the expiratory phase of the NeoPuff and breath delivery, and the effects of using a flow restrictor to create PEEP, and that's what the NeoPuff does. We have a kind of a set device here with the little cap that goes on the top like this, and a little hole that goes through here. All right. So the flow coming back through the NeoPuff from, this is towards our patient, this is how the PEEP is created, by creating this bit of background resistance. And that's an important factor because it's in this opening here that we're going to control our expiratory resistance during exhalation. So by using lower flow rates, this opening has to be much smaller than when we use higher background flow rates. So the size of this opening right here at the NeoPuff controller, right at the patient connection, is going to be much more open when we use higher flow rates. So we'd expect to see this, and we could actually measure it. So that's what this data here shows, is that when we choose the 6 liters per minute, we have very, very high expiratory resistances compared to when we choose the 15 liters per minute driving flow rate through the NeoPuff. All right? And what this relates to is that we see this really big change in our time it takes for our expiratory flows to decline to zero. So our TE dynamic is greatly reduced when we choose the higher background flow rates through the NeoPuff. So this has implications with our patients in that, one, if they were spontaneously breathing, the ability to exhale quickly and effectively. But even in this example where we're mechanically ventilating the patient, you can see that if we are using really lower flow rates, such as 0.8 liters or 8 liters per minute, we're going to have quite a prolonged expiratory phase here before we can get back to zero flow. So if you're ventilating at higher rates, you could very well be causing some air trapping and some auto peep within your patient. Where at the higher flow rates, such as 12 or 15 liters per minute, your expiratory time is the time it takes to get equilibrium between mouth pressures and circuit pressures or lung pressures is dramatically reduced. So your TE, your expiratory time, and time to get to equilibrium is dramatically reduced. So that's a consideration, and one that may alter your view on what kinds of flow rates you want to use with your NeoPuff. So this is a detailed view of the expiratory phase using a positive pressure breath to the NeoPuff, and you can see that we've got a nice sharp expiratory waveform here with a high peak expiratory flow, and the TE dynamic is, even at the 10 liters per minute, is about between 0.4 and 0.5 seconds before we get equilibrium between lung pressures and circuit pressures. So we still have this dynamic flow, and you can imagine that if I'm ventilating at a rate of 60, where I may have even slightly inverse I ratios, I want to keep control on this so that I don't have breath stacking or possible breath stacking. The peak expiratory flow here that we're seeing is again can be represented by the change in pressures over the flow. So we have a known resistance, and this is how this was calculated. We didn't know the resistance, but we can measure the changes in pressure, and we can measure the flow rate from the ASL5000, and that's how we derive the resistance in our circuits and in our system. So this is a graph looking at our data as we are calculating the resistance using that equation that I just showed you. We did it a couple of different ways, and you can see the trend is the same, that as you increase the background driving flow through the NeoPuff, resistance or expiratory resistance dramatically decreases from a high of about 120 centimeters of water pressure per liter per second to a low of about 40. So I mean it's a considerable drop in delivered or the imposed resistance to exhalation. So it's a good thing to do is to compare our observations with some other observations. And if you remember, we were looking at some of the data that Wald produced and published. And when I look at that, so we've just plotted the data that we calculated with this little kind of triangle thing here. And you can see we've got the NeoPuff at 6 liters per minute, at 15 liters per minute. And then we're comparing it to the infant flow or the CPAP ventilator. That our data closely resembles the data that Wald also discovered. So we seem to be very close in our measurements as compared to the little bit different methodology that he used. But we're getting pretty close similar data. So you can see we've got a high resistance at the low driving pressures, dramatically reduced at the higher driving pressure or driving flow rates, and we'll show you some data from the infant flow or the CPAP ventilator. So one of the other things I wanted to look at was to see how well the NeoPuff controlled spontaneous breathing through an endotracheal tube. So I thought, well, if you've intubated your patient, how does that result and change the data that we see ventilating a patient with the NeoPuff? So we can give positive pressure breaths, and I also eventually I'll show you some data where we look at spontaneous breathing. So now we're going to compare positive pressure ventilation through a 3.0 endotracheal tube with the NeoPuff, and just as a comparison, I was looking at it as compared to the servo I ventilator. So here's a detailed diagram, a graph representing the NeoPuff with a background flow rate set at 15 liters per minute. So we're trying to optimize that positive pressure delivered. And here's a servo I ventilator ventilating the exact same ASL5000 situation, and we can do a comparison between the two. Now, so here's our pressures delivered, and here's our inspiratory flow waveform. So we see as we would expect, that high peak inspiratory flow being delivered to our patient, and we see that it takes about 0.5 seconds approximately to get equilibrium. So our TI dynamic is about 0.5 seconds. And right off on the NeoPuff, you can see even though we don't achieve nearly the same kind of peak inspiratory flows, because of the efficiencies within the system, we get equilibrium being delivered much quicker with the servo I ventilator. Now, so this is a passive patient being mechanically ventilated with each device, and we can see that you could have actually much shorter TIs established when using the servo I ventilator. Even though our peak flows are quite a bit less, we still seem to get equilibrium much quicker. So this seems to be controlled by something internal on the NeoPuff rather than just strictly the resistance of the endotracheal tube. There's some background flow decline here, probably because of something inside the NeoPuff pressure limiting switch mechanism inside the NeoPuff itself that somehow slows down the equilibrium between mouth pressures and lung pressures. The servo I ventilator doesn't seem to have that as much. It's interesting that the delivered tidal volumes were consistently a little bit higher with the servo I, even though our pressure gradients were almost exactly the same. But I'm not sure if a half of or a 0.4 mils is significant. As far as the expiratory flows, we can see that they're very similar. Expiratory flows do seem to be due just to the pressure gradient. There seems to be almost no effects or no differences in the duration it takes for XTE or expiratory time to be achieved between the two ventilators. So it's these limitations in the inspiratory flow that seems to limit us a little bit with the NeoPuff, but I think you could still ventilate a patient quite effectively at those higher rates of about 40 to 50, and because at the higher background flows through our circuit and the lower time it takes for exhalation, the possibility of air trapping is quite limited with both, whether you use a servo I ventilator to give positive pressure ventilation or the NeoPuff. One of the effects, though, of achieving equilibrium a little bit quicker is that you do see a little bit longer inspiratory pause during inspiration with the servo I if everything else was set the same. So if TI was set at 0.5 seconds, you can see I'm going to have a little bit of longer duration of an inspiratory pause, and this could allow for a little bit better distribution of ventilation, or potentially even a little bit better alveolar recruitment could possibly be occurring. Another kind of experiment that I did with the NeoPuff was to compare it to the CPAP, or the infant flow ventilator. The CPAP is a common used device to deliver CPAP, and I thought, well, let's compare how effectively the NeoPuff delivers CPAP as compared to the CPAP device. So this is an unassisted spontaneous breathing model that I was using with the ASL5000 now. So I thought we would compare how a patient spontaneously breathes through something like the NeoPuff as compared to the CPAP infant flow. So this is a rather complex diagram, and what we do is, right now, the ASL is spontaneously breathing through that tracheal model, which is that 5.0 endotracheal tube. So this first breath that we're looking at here is just the ASL5000 breathing through that 5.0 endotracheal tube. So with our initial settings, work of breathing established on the ASL5000 and our 5.0 endotracheal tube, we see, if we zoom in really carefully here, you'll look in and you can see that there's very little spontaneous work of breathing. The amount of pressure that required to breathe in and out and to get this inspiratory flow and expiratory flow is very minimal. So breathing through the 5.0 endotracheal tube requires very little work on the part of the patient. All right, so we consider this to be kind of our standard, our set point for the comparisons. Now, when we put the NeoPuff on with a background flow of 6 liters per minute, we'd expect to see this, as we do, this prolonged expiratory phase here because of the setup of the NeoPuff PEEP valve. All right, but what we also see is we've got this deep dip here in our inspiratory pressures, and this dip in here corresponds to this small little change here, but of course we're being set at a background CPAP level right now, where here we could not establish a PEEP or a CPAP level because we were just spontaneously breathing. So the NeoPuff is nicely controlling, and we have a nice CPAP level of 6 centimeters of water pressure, but we're creating a significant amount of inspiratory work with our patient because they have to draw down this large amount of almost about 3 centimeters of water pressure to draw the breath in. And you can see that limits our inspiratory flows and prolongs our expiratory flows. So here, this is our work of breathing through the NeoPuff system set at 6 liters per minute. Now when we increase the background flow to 15 liters per minute, you can see I've got a little bit less dip here. It's only about 2 centimeters of water pressure to create breathe or extra work created for my patient to breathe in and out. Now, I had to adjust the PEEP to 7.5 to actually get delivered approximately 6 centimeters of water pressure. So we have to compensate for that, the effects of the manometer system in the NeoPuff. But when I do that, you can see I've got a nice even CPAP level set, and my TE dynamic is considerably shorter when I use that 15 liters per minute. So this is a spontaneously breathing, and you can see I've induced some work of breathing, but it's quite a bit less than with the higher background flow rate established than the lower background flow rate established with the NeoPuff. You'll also notice that the TE dynamic, the amount of time it takes to get equilibrium during exhalation, and the peak expiratory flow is dramatically improved when I choose the higher background flow rate with the NeoPuff. So I think these are positives. You just need to make sure that you correct for the error in the NeoPuff pressure manometer, which is induced, I think, by some of the internal flow dynamics of the NeoPuff. This could be improved dramatically if we used actually measured the pressures directly at the PEEP valve instead of back inside the ventilator. Now, here's an interesting observation. When we use the NeoFlow or the CPAP to deliver our CPAP to our patient using those nasal prong systems that they have, you'll notice that the induced work of breathing through the CPAP is very low compared to the NeoPuff. So this could be very advantageous if we want to induce very little work of breathing on our patient. We can effectively maintain a high level of CPAP so that we have that recruitment and then breathing at that higher FRC, possibly reducing the work of breathing. And you'll notice I'm also getting very, very high efficient expiratory flows. So the work of breathing on exhalation is also dramatically reduced. So the CPAP ventilator looks like a really good choice to deliver CPAP for my neonatal patients. The induced work of breathing is dramatically lower about approximately half of what the induced inspiratory work of breathing is on the NeoPuff, and expiratory flow is also greatly enhanced and reduced, so the expiratory resistance is approximately half of what the expiratory resistance is on the NeoPuff, even at the higher background flow rate. So these are some important considerations when trying to deliver CPAP to a spontaneously breathing neonatal patient. Now, one of the last things I did was I looked at, well, when we have a intubated patient who's spontaneously breathing through a 3.0 endotracheal tube, what's the effects of that? So we don't use something like the CPAP for an intubated patient, but sometimes we do use the NeoPuff for short periods of time to allow the patient to spontaneously breathe when we've intubated them, say, in the case room. So what's the difference between ventilating or allowing a patient to spontaneously breathe through that 3.0 endotracheal tube as comparing the NeoPuff to something like the servo-I ventilator? So let's take a look at that data. So once again, we started off looking at just a spontaneously breathing a patient. So this is the exact same parameters we were using just a few minutes ago, comparing the NeoPuff and the CPAP ventilator. So it's the same ASL5000 tracheal model, except now what I've done is I've intubated the patient. So we've replaced our tracheal model with a 3.0 endotracheal tube. So the induced work of breathing through that 3.0 endotracheal tube is significant. You can see that I've got a drop down in pressures here, and that's a dramatic change and increased work of breathing once we've intubated our patient. So that's something to consider. It limits our peak inspiratory and our expiratory flows. So the patient has to do a lot of work just to get that same tidal volume in. All right. So now let's compare the NeoPuff at 15 liters per minute, and we see, okay, I've got that induced work of breathing through the 3.0 endotracheal tube. But what's surprising is it's not that much more induced work of spontaneously breathing compared to even just with the tracheal model. It seems like a large part of this work of breathing is induced by the NeoPuff itself rather than the endotracheal tube, because this waveform looks very similar as when compared to the unintubated or the tracheal model. We see that peak inspiratory flow is declined, and we still see that we have this prolonged expiratory phase due to the expiratory resistance. The tidal volumes recorded were considerably less because we've got induced this work of breathing for our patient. So we've controlled that with the ASL, so I'd expect to see a little bit lower tidal volume and being delivered with that same amount of effort because of the induced work of breathing through the NeoPuff. Now, let's compare that to the servo-I. So we have a spontaneously breathing patient, and we can see the amount of work being generated is almost the same. The duration of negative pressures required to get the breath is somewhat limited in the servo-I. And I've looked at this a couple of times and have noted that there's this difference in performance here. And you'll notice our inspiratory flow rates, initially, they start off with the patient breathing, and then we get this little bump here. And I suspect that's because the servo-I is augmenting, even though it's in the CPAP mode, is kicking in with a little bit of pressure support. And that's why you'll see our tidal volumes being a little bit larger here than with even the spontaneous unassisted model, even though we've induced some work of breathing. But we do see a good peak expiratory flow here, so the expiratory resistance is dramatically lower on the servo-I, but I think the NeoPuff does a respectable job of delivering that tidal volume and assisting our patient maintaining that PEEP level, or that CPAP level, of 6 centimeters of water pressure. So we've induced some work of breathing, but if we had him on the servo-I breathing through the 3.0 endotracheal tube, the work of breathing is pretty similar between the two. All right. There is some differences on the expiratory flows, so the patient would experience possibly a little bit of air trapping if they had a high rate. But how important that is, that's a difficult clinical question, but certainly the expiratory phase is slightly prolonged with the NeoPuff. So I think these are some pretty interesting observations with an intubated spontaneous breathing patient. So in conclusion, I just wanted to state that the data that I've presented to you today has not been peer reviewed. It has been independently verified by some institutions like the Foothills Medical Center. So they've seen some of these same observations. They haven't generated the same kind of detailed graphs that I have, but I do believe there are some other researchers looking at that. We just have not published our data at this time. But I still think we can state that the NeoPuff does create, as both my data and Wald's demonstrates, higher expiratory resistance at low circuit flow settings. So you can dramatically reduce the expiratory resistance by using higher background flow rates in the NeoPuff. The NeoPuff does not measure CPAP or PEEP very accurately at the higher background circuit flow settings. So clinicians should be aware of this and perhaps compensate for this if you're using those higher background flow rates of 10, 12, or 15 liters per minute. You should probably be increasing your PEEP levels. When intubated and using the positive pressure ventilation and at time of resuscitation, the NeoPuff seems to be very effective at regardless of the settings, but particularly at the higher circuit flow settings, and delivers comparable breaths to something like the Servo-I when intubated and delivering positive pressure ventilation. So that's a high recommendation of the NeoPuff, delivering a very effective ventilation. When we look at spontaneous work of breathing through something like the NeoPuff, we see that the spontaneous work of breathing through something like the NeoPuff is dramatically higher when compared to something like the CPAP, but the CPAP is really geared up to be delivering long-term nasal CPAP or PEEP pressures, where the NeoPuff is really short-term for resuscitation. So it's still a very effective device for this, but certainly what this data suggests to me is that you'd be wanting to switch over to the CPAP as soon as possible to reduce that spontaneous work of breathing and to effectively achieve the CPAP levels you're looking for. Some other conclusions might be that with positive pressure ventilation through a mask, there's possibly a problem with air trapping or inverse IE ratios when you're using the NeoPuff due to the prolonged TI and the high expiratory resistance. So that's a consideration that you might think about when using that. So you might choose, as I recommend, a little bit higher background flow rates with the NeoPuff and then compensate for that altered PEEP levels. So if you're using 12, for example, or 15 liters per minute as your driving flow rate through the NeoPuff, you should probably be setting your PEEP at those higher flow rates, probably about +1 to +1.5 centimeters of water pressure higher at those higher flow rates. So if you'd like to look into this a little bit closer, I've included a list of references here. Here's Wald's study, and there's some others that you could look at here to compare and to do a little bit more background reading on this. I do believe that respiratory therapists should be experts in all aspects of mechanical ventilation, and by exploring things like these details of these patient-ventilator interactions, we can make sure that we understand how to best optimize and utilize the equipment we have available to us. So I really do appreciate any discussion that we could have about some of the ideas that I bring forward here about using the ASL or the data I have looking at the NeoPuff, or just any comments or thoughts you have about ventilator-patient interactions. So please contact me with any of your questions or thoughts or ideas. I'd be glad to hear from you. My name is Alan Prost, and please feel free to contact me. Here's a good email address to do that with, alanprost@sate.ca, so alan.prost@sate.ca. You can send me any questions or comments. Thank you very much for your kind attention today.